trained in Harvard in global health. And so these are our guest speakers next week. Oh, let me put it up, yeah. So that's so at 6 p.m. Singapore time, and the QR code is there. So we have three very eminent speakers. So Dr. Aishwarya is a global health practitioner, trained in Harvard, but now practicing in, I think, somewhere in southern part of the United States. And then Dr. Naresh Babu is a retinal expert in Aravind and also done a lot of work with diabetic screening in the community. And Dr. Coimbatore, who's working with a tribal population in the eastern part of India. So how to help take care of the eye health of the tribals in the eastern part of India. So please come. Please tell all your friends and trainees. The more the merrier. And we hope it will be a teaching session. We are hoping that this will inspire more of our trainees to go into global health. We are also hoping that more people will be applying for the Singapore National Eye Center Global Health Fellowship, which is a paid fellowship for a year. So during that fellowship, they get training in all aspects of ophthalmology as well as global health. So please encourage your trainees to apply. So with that, I think we're going to start today's session. So today's session is going to be slightly different because we are going to present cases that are trying to cover some of our lacunes in our knowledge. So this is the first case is a patient that we don't often see in our parts of the world. And I've been struggling with him for the last 3 months. So we are hoping that the experts in the audience could help me solve some of these diagnostic problems in this patient. So chief resident here is Alvin. He's going to lead the show. We're going to use this some of the problems that arise from this patient as questions to help train our trainees. So he'll be directing the questions. And our guest in Coimbatore, in Hong Kong, please feel free to chime in and answer. We are very honored to have our guest from Hong Kong Ophthalmological Institute, led by Carmen. So please feel free to ask your trainees the same question also, and we'll be happy if they can participate online. And then at the end, we hope to open the discussion, and I'm hoping to learn something from all of you so that we can help this patient. So with that, the presenter is actually Dr. Jasmine. We call her the younger Jasmine because we have two Jasmines in the department. And interestingly, the flower of where Aravind is a town called Madurai, and it's famous for Jasmine also. Oh. So there is a story to all of it. So three Jasmines coming together. Okay. So Jasmine, go ahead.
Yeah. Okay, good evening everyone. I'm Jasmine. I'm one of the year 2 residents at SNEC. So I'm presenting the first case today on behalf of Uma. So this is a 65-year-old Caucasian male who's currently living in Singapore. His past medical history, he has hypertension. He's also been started on prophylactic aspirin of 100 mg OM as recommended by his doctor in Germany. And he's also an ex-smoker as well. In terms of past ocular history, he has a right eye active retinal membrane as well as a left eye vitreomacular traction. So he first presented to us at the start of this year. He was actually referred as an inpatient blue letter to us. He first presented to the emergency department and he was admitted under the neurology team. So he complained of this acute onset of binocular oblique diplopia of 1 day. He was just sitting down using his computer when it occurred, and it was constant with no diurnal variation or any fatigability. And he felt that it was getting progressively worse since its onset, but there was no change in the varying gazes. He also had a right upper lid ptosis, and it became a complete ptosis just within the span of 1 day. He complained of worsening right eye retroorbital pain as well after his admission. Otherwise, there was no monocular blurring of vision, no raised ICP symptoms, no focal neurological deficits, no constitutional symptoms, no GMG, GCA symptoms, no fever or any trauma. So examination, vision was actually quite okay, pinhole to stage 12, 6.9, and the anterior and posterior segment was unremarkable. On the examination, so there was an anisocoria that was worse in the light, the right pupil larger than the left. So in the dark right was 6 mm, left was 5.5 mm. In the light right was 5.5 mm, and left was 2.5 mm. He had a complete right upper lid ptosis by the time he came to see us. In terms of extraocular movements, he had a right abduction deficit of -4, elevation deficit -3, depression -4. Abduction was otherwise full. And this was noted to be very rapidly progressive because he was seen by the ED as well as the neurology MO that very morning, and he only had a very slight abduction limitation, and his vertical movements were full that morning. Otherwise, optic nerve function was full, contiguous cranial nerves 5, 7, 8 were intact as well. This was the orthotics assessment. So there was a large right exotropia that was better on right gaze. Otherwise, he was not able to really fix it well in up left and down gaze because of the ELM limitation.
So I mean, be honest.
Maybe get Zhao to answer this question. So at this point of time, the patient essentially has binocular diplopia and ptosis.
You want to come forward? Mic is nearer. Oh, they can hear? Oh, come nearer. Don't be shy.
At this point, we talking about criminality policy, this pupil involvement in view of the ptosis, EOM limitation, and also lysophora was in light. That's my top differential. Some things will be less likely in this case, such as ocular myasthenia gravis, but it should
Pupils are involved.
Yeah, but should affect the pupil. Or I think the most important thing is to rule out the surgical third nerve.
Surgical third nerve, okay.
So in acute setting, I think should get angiography of the cerebral vessels, be a CT angio or MRI angio, and also a MRI brain or CT photo.
And particularly, what are you looking at?
Looking at for any aneurysm, particularly over the posterior communicating artery, or any uncle herniation, less likely in this case because patients well, resized.
Thank you, Sharon. So as Sharon correctly mentioned, so we proceeded with the MRI brain, MRA with CN3 protocol with contrast. But there was actually no enhancing intracranial mass or any abnormalities noted along bilateral CN3. The vessels were okay as well. There was no aneurysm that was noted. We also sent off the GCA bloods in view of patients' age. Platelet and ESR was okay. CRP was not done in the admission. We also sent off a thyroid function test as well that was normal. We screened the cardiovascular risk factors. So he had raised LDL as well as TG. So we started the patient on atorvastatin. Otherwise, he had no diabetes. So impression at this point on time was that it was a right pupil involving CN3, but possibly ischemic as the MRI brain and MRA was negative. Although it's unusual for ischemic CN3 to be pupil involving, but it's not impossible. So our plan was to review again in 4 weeks' time to assess his progress. However, the patient.
But at that time, there was also neurology also did a spinal tap, right?
In the next.
Okay, sure. Please carry on. Yeah.
So yes, he came back again 5 days later
Sure.
because he complained of this right eye worsening pain of 1 day. He described it as a sharp pain that was radiating from the right forehead to the retroorbital area and to the right cheek, and that was worse on eye movements. He was really complaining of some forehead tingling sensation a few days ago when he was discharged. And when we saw him again, CN5 was intact. There was no vesicles seen to suggest shingles. Rest of the neurological examination were quite similar. So because of this new symptom that he had, we actually repeated the MRI scan again, this time with a CN5 dedicated protocol.
Somebody is saying that the voice is not clear. Is the voice okay? Yeah. Maybe we put it nearer.
Okay.
More like the echo. So
It's the echo.
yeah. I think you just leave it, but I'll check on the background later.
Okay,
I'll
thank you.
send you a picture.
You're checking, yeah?
Yeah.
Oh, yeah, so good. Thank you. Yeah, okay.
Okay, so we
We just
repeated.
take slower.
Okay, we repeated another MRI brain, this time with a CN5 dedicated protocol. And now there was this new enhancement that was seen along the right cranial nerve tree that was previously not seen. Otherwise, the cranial nerves 5 were actually okay. There was no optic nerve enhancement and no intracranial problems as well. So although it could still be an ischemic issue, now with the new enhancement seen, we have to rule out whether it could be inflammatory, infective, or infiltrative causes. So we did quite an extensive workup. We sent off the blood test, autoimmune and pre-steroid workup. So ESR, IgG, anti-ANA profile, ANA, anti-dsDNA, ANCA, they were all negative. We also did a BDRL, Hep B, C, HIV screen that were negative as well. And the neurology team also did a lumbar puncture. And the opening and closing pressures were okay. Besides a little bit of high protein, actually the infective screen was negative, no oligopolar bands, flow cytometry also was negative for lymphoma screening. We even did a CT thorax abdomen pelvis, and there was no focal inflammatory change or any malignancy that was seen. So because of the extensive workup that was done, that was all negative, our impression was that it's likely still an ischemic CN3 palsy, and the pain could be due to a right V1 pure sensory kind of neuralgia, and we kept the neuro off appointment that we wanted. So he came back, this was about 1 month since his presentation from the diplopia, and he felt that his diplopia and ptosis was about the same. He had no complaints of any blurring of vision or any new systemic symptoms.
Jia, you mind helping us describe the photos?
From the like because it's not the owner project.
Okay.
The patient's right.
Who's that? Oh, you want to come forward? You can hear from there?
I don't know.
Yeah, maybe come forward, please. Yeah, thank you.
These are photos. Okay, so the photo on the left is a photo of the patient's right optic disc. So the coverage ratio is about maybe 0.1, and the margins look a bit indistinct, but there's no, I mean, with slight obscuration of the vessels, 360 degrees. I do not know any peripapillary hemorrhages or any patent lines surrounding this. On the photo on the right, the disc also looks with a coverage ratio looks about 0.1 pink. The disc margins, this one looks more distinct. There are no peripapillary hemorrhages or patent lines.
Yeah, I think the photos are not the clearest, but like what Jiang pointed out, they were both very crowded, this 0.1, 0.2 have this ratio. The one on the right, the margins, yeah, the margins are not as distinct compared to the left, especially at the nasal margin. And there's this small peripapillary hemorrhage over here at the inferior nasal part of the disc. So the vision now was, in the right eye was 619 pinhole to 615. And we felt that there was this segmental swelling nasally with the peripapillary hemorrhage. So on neurological examination, HRR was still full in both eyes. In view of the anisocoria, we did REPD by reverse, but there was no REPD. On confrontation, there was just slight constriction of hand movements in the outer quadrants. Otherwise, the ptosis and the UM limitation was about the same. We checked the temporal arteries as well. It was pulsatile, there was no thickening or any tenderness. So this is the OCTR, NfL, and GCIPL. So as you can see, the OCTRFL, the right disc is swollen with a thickness of 238, and it's worse, especially inferior nasally. The left disc is okay. The GCIPL is kind of confounded by the ERM and the BMT, so can't really be interpreted very nicely.
See, the left side is normal.
Left disc.
Yeah.
I mean, based on the measurements, they are quite.
Yeah, I
And
wasn't
like
sure.
what Justin said, the left GCIPL can't really tell because there's a epiretinal membrane
I see.
which kind of distorts the image.
Sure. I was a bit struggling with the left side. Right side, okay, we were quite sure. But left side, we were not sure. But it was at this point, if it was bilateral swelling, then it was very important that we look back at the spinal tap and we made sure that the pressures were normal. Okay, but I think eventually we decided it was only the right side that's swollen.
This was the Humphrey visual field. So the left eye, there was some inferior defects that were seen. The right eye was not reliable, but there seemed to be some superior nasal defects as well.
So should we ask somebody what they think about this swelling? Who?
Jia again.
Should we rotate? Yeah. Joy. Yeah, Joy, come forward and what do you think of this swelling? He's got no symptoms. Luckily, it was Dr. Julian who saw the patient because I would have missed the swelling. So, because he has absolutely no symptoms. In the fields also, only the inferior field is affected and some swelling. So, how would you interpret
I
this?
didn't actually catch the first part because I was
Oh,
in
sure,
clinic,
sure.
so I just came. So
Fair enough. Okay.
I,
What do you think
mean,
based on this alone?
based on just this
And then
HVF
I'll-
is like almost like an altitudinal defect,
Yeah.
and then I would be concerned if the patient had like a non-arteritic ischemic
anterior optic neuropathy.
Yeah, but the vision is so good.
Yeah,
And
but
so
I think there's also EUM limitation.
yeah,
So
there was something in the past, right?
oh,
So, but
okay.
but based on this alone,
Yeah.
Your impression would be an impending AON, right?
Yeah, possibly non-arteritic anterior ischemic optic neuropathy. So I want to know the patient's age and the ischemic risk factors also.
But then
Yeah.
if we told you that the part that you missed was that this man had a pupil involving third nerve 2 weeks ago associated with pain. So then your thoughts would be?
I'll be thinking about opto apex lesion.
No, they ruled that out with
ruled
MRI.
out. Oh, okay. Or some sort of inflammatory.
Oh, you said non-arthritic AION, right?
Oh yeah, right.
So now that-
arthritic.
Yeah. So now you have to think about arthritic.
Yeah, right. Like along
Especially because he's a
GCA.
Caucasian man.
Okay.
Fair enough?
Yeah.
Okay.
So we were worried if it could be an arthritic AION from GCA. So patient was started empirically on oral prednisolone 60 mg OM. Previously pre-surgery had already been done. So repeated the GCA bloods, they were all normal. And for a right temporal artery biopsy by the oculoplastic team, it was negative for GCA. We did some autoimmune markers as well, and the IgG4 was 0.85, which is normal, but upper limit is 0.86, so it was quite borderline. So we also recommended for PET CT scan, which we did in private, and it was negative for any IgG4 disease or vasculitis. So he came back about 10 days later, and he was complaining of a worsening right eye vision despite being on oral prednisolone. Vision was 6:15, Ishihara was full. There was now a bright grade 1 RAPD by reverse. We repeated the OCR and FL. The right disc swelling seemed quite similar in terms of the thickness from 238 to 229. However, when we compared the HVF, granted that the previous one was unreliable, but it seemed like there was a worsening of the visual fields, peripheral visual field defects, both superiorly and inferiorly. These altijuvenal defects has been seen. So in view of the worsening HVF, and patient also subjectively felt that vision was worsening, we admitted the patient. And we also started the patient on IVMP, IV methylprednisolone, 1 gram per
So we
day.
increased it from oral 1 milligram per kilogram to a pulse methylprednisolone.
Yeah, for a total of 5 days. The GCA bloods were repeated once again. It was okay. We also sent the patient for a fundus fluorescein angiography. There was no convincing signs of any GCA. In view of the new disc swelling, we also sent for a MRI brain and ABP with contrast. There was no orbital methane, and optic nerves and chiasm was also okay. There was no enhancement. And then the right CN3 enhancement was once again seen, as shown in the arrows that's pointing out at the photos on the right side. Just to be sure, we also sent for an ultrasound temporal arteries, and there was no halo sign to suggest GCA as well. So this was the review on 23rd February after completing 5 days of IVMP. The vision was now 612. We felt that vision was about the same. RNFL thickness about 200 now, and HVF defects looks quite similar. So we discharged the patient with tapering dose of oral prednisolone. So this was about 2 weeks later. Vision was now pinholed to 6.9. HR right 7 out of 10, left 8.5 out of 10. Like Ishihara was full with still a right grade 1 RAPD. However, notably, his EOM limitation was actually improving. So now the A deduction of -3, elevation -2, depression -1. And the right ptosis was also improving. The PA was right 5 mm, left 8 mm. And then when we repeated OCR and FL, this swelling was coming down. The thickness improved from 200 to 143. And it seems like the visual field defects was also improving compared to on his discharge. So we continued tapering the oral prednisolone every 2 weeks. And we also started the patient on a steroid-sparing agent on oral CellCept 750 mg/d. So however, he came back again recently because of worsening right eye vision. HR was still about the same, right 8 out of 10, left 9.5 out of 10. So we can see that compared to when he was discharged on 23rd February to when he walked in, there seems to be some worsening of the visual field defects. So we increased the CellCept to 1 gram BD for him and continued tapering the oral steroids, and he's still on regular follow-up with us currently. I think that's the end.
Okay, you want to help us summarize and then?
Yes. So this is a 65-year-old Caucasian gentleman. So he first presented to us with a right pupil involving CN3 palsy. following which he had a right CNV1 sensory neuralgia and then had a right optic disc swelling, presumed to be possibly inflammatory in nature, whether it could possibly be an ESR negative and biopsy negative GCA.
So yeah, just to paraphrase it again. So the main feature is an elderly Caucasian man who presents with an acute pupil involving right third nerve with no other pathology at that time. And then soon after that, he developed some pain around the forehead. He had no inflammatory signs at that point, but about 2 weeks later, he started developing what looked like an asymptomatic altitudinal visual field defect with optic nerve swelling, anterior part of the optic nerve swelling, that subsequently went on to produce visual impairment. And so with that combination of second nerve and a third nerve with nothing in the orbital apex, documented twice with a dedicated MRI and a normal spinal tap, even though the ESR, CRP, and the platelets were normal, we decided that this may be giant cell arthritis. So we gave him high-dose steroids. There seems to be some worsening at the beginning, and then eventually it kind of plateaued out to a moderate defect in the right eye with no involvement up to now of the left eye. But the problem we have is that we literally threw the kitchen sink at him, right? The PET scan is normal. The biopsy of the temporal artery on the same side is normal. The ultrasound of the temporal arteries is also normal. And so we wanted to bring up this case to, he's stable on medications. His third nerve is slowly improving without any signs of aberrancy. So there is, so it looks like doesn't behave like a third nerve that's recovering from a mass lesion. So it's recovering in a very coherent manner without any aberrancy. So I still think that this is a GCA, except that for some reason we can't get any specific diagnostic feature. So I thought I'll bring it up to the general audience for comments. So please unmute yourself and tell me what you think or any questions you have on the case. And any other suggestions? Dr. Tina, do you have any comments from your side? You have retinal experts there also.
Yes, sir. Like again, not able to explain the optic disc swelling. Even if it is GCA, the amount of pallor, the amount of edema, and the amount of vision loss are quite less for a GCA. Normally, you tend to see a lot of pallor, a lot of edema, and a lot of vision loss. Either we caught it too early to untreated them. Maybe that's why it didn't manifest into full. And also the other associated findings, right from biopsy to the ultrasound, everything was normal. So DSR was also, CRP was not done, but DSR was normal.
Yeah, but subsequently CRP also negative.
Okay, so it's very difficult to pin it on GCA, even though you say that it could be. Biopsy, at least sometimes you could get a normal segment, that is okay. But in spite of that, no other associated finding is going towards GCA. Even the routine systemic features, no significant features. So I'm not very sure about. I understand it's looking more like inflammatory edema, but to pin it on GCA, I think we lack any sort of evidence.
Yeah, but the difficulty I had is that I couldn't get an alternative diagnosis. You know, there's this section in one of Sherlock Holmes' books about how after you've ruled out all the probabilities and then even whatever there remains, no matter how implausible, that may be the only diagnosis then. So I'm not saying it as well as he said it, but that's why we couldn't find an alternative explanation for this patient developing third nerve and second nerve at the same time. So that's why, for want of a better thing, we're thinking of GCA.
I understand. Like that's what after ruling out all the other possibilities, whatever remains has to be true.
Mm.
That is what Dr. Watson tells
Yes.
Sherlock said tells to Watson.
Yeah.
Anyway, somebody is asking about tolosartan, but tolosartan should have more findings in the MRI, I guess.
Yeah, we don't like to use the word tolosartan only because it's an idiopathic painful ophthalmoplegia, right? And the thing is, it's here the third nerve came without pain first. The pain came later, and then much later, as the third nerve was recovering, then the second nerve came. So that time course is not the usual type we see in the so-called idiopathic tolosartan, right? But nowadays, of course, we are realizing that most of tolosartans are either inflammatory orbital disorders like IgG4 and things of that sort. So along those lines, we did do the IgG4 levels. And then we also did a PET scan to see whether there were any lymph nodes that we could biopsy, because in IgG4 disease, often there's lymphadenopathy.
What about the MRI findings in so-called tolosartan, sir? What are the other, like here we just had the enhancement of the optic third nerve only.
Yeah. So that's the part that we couldn't explain because only the third nerve is enhanced. So of course we're going to do follow-up scans to make sure that it's not an infiltrative lesion. So as you know, for Caucasians, if they have melanomas or something on the face, sometimes it can infiltrate into the cranial nerves. So we did examine him very carefully to make sure there was no facial malignancies. But nevertheless, I need to make sure that, yeah, so Jasmine had put up very nicely one of the thoughts that we had also.
Okay.
Must congratulate her for thinking of this.
Yeah,
So this is something that we have to keep in mind and repeat the scans and make sure that the lesion is not becoming bigger on the scans. But the third nerve is improving clinically, which is not expected in perineural spare.
So should MOGAD also be done in these cases?
I don't think we did MOGAD, huh? Yeah, because we couldn't explain yeah, we didn't do MOGAD. Also because there was no enhancement of the second MRI didn't show. Yeah. Yeah, so I think that's not a typical MOGAD manifestation, right? So we didn't do it. And you know, MOGAD is one of those where sometimes in low titers you can get it in other diseases. So we always say that we must have a significant pretest probability before we do MOG. And often we look at the titers of MOG. So in this case, I'm not sure whether MOGAD can explain, but any other thoughts from anybody else? Our Hong Kong friends are around? Dr. Carmen and Atim?
Hi. We've just been discussing between ourselves whether this can be MOGAD or not. But
tell me.
No, it's less likely.
Okay, we didn't think about MOGAD, but you know, we are open to testing it if you think that if everyone in the audience or significant proportion of people in the audience feel that it's likely.
But the patient is currently on steroid and CellCept, right? So that will increase the false negative rate anyway. So, but even if it was MOGAD, if it's responding to treatment, then I think you're treating the patient in the right direction. So
his response was a little bit slow, and you know, it seemed like the visual impairment got worse and then plateaued out, and then it's remaining in that state. He hasn't reversed any of his deficits, and there was a period of progression while he was on steroids. So that's a bit odd for us, yeah.
Right.
He wasn't very responsive to steroids, which points against MOGAD, right? Because MOGAD patients will respond.
Yeah, MOGAD or IOID should respond quite well to steroids. And as you say, the lack of response is just
ischemic. Third nerve and ischemic second nerve.
Yeah, but if it was ischemic, but the visual field pattern is not too suggestive of AION, right?
Yeah. Initially, that was a bit odd to know, but then subsequently it became a C-shaped sort of visual.
Yeah. Interesting.
So he's actually a very well-informed and very well-informed but pleasant gentleman who asks very interesting questions. And his daughter, neurology trainee in UK. So so they'll be very interested in the discussion. They're not in the call, of course, but they'll be very interested in the comments of the experts.
Thank you.
Is there any other? The other thing I thought we should bring up is that we often, whenever we see a patient with pupil involving TED, the moment we rule out a giant cell, the moment we rule out a PCOM aneurysm, we tend to kind of relax, but we must remember there are other causes of pupil involved. So maybe, Jasmine, maybe you can remind us of some. This is from Dr. I'm blocking on the name now. So this is from one of the famous textbooks and Dr. Nancy's book. Yeah. So you can see that the third nerve is nicely drawn out on a radiological image. So we can see how the green third nerve is coming through the red nucleus, then it passes the cerebropeduncle and comes out. As it comes out, it meets and goes along with the PCOM posterior communicating artery until it meets the internal carotid artery, right? Then after the internal carotid artery, it goes up to the cavernous sinus, and then it goes into the orbital apex. So we must remember that that after we have ruled out PCOM aneurysm, there are other things, including internal carotid artery aneurysm too. Yeah, so that's why in our setting, we often ask for MRA and together with the MRI of the brain with the anterior visual pathway, so that once a PCOM aneurysm is ruled out, we consider the other possibilities. And Jasmine, is there any other teaching points you want to highlight?
The part about
Yes.
yeah, so basically actually now with the modern imaging technology, detection of aneurysms that's large enough to cause a surgical TED is actually 100%. So usually the PCOM aneurysm should be at least about 4 mm to cause a CN3 palsy, and most of the CT and MRA now is able to detect any aneurysms that is equals to or bigger than 3 mm. So the accuracy rate is actually nearly 100%.
And the reason we favor an MRA over CTA is because at one sitting, we can also get a MRI of the brain and the anterior visual pathways, right? So maybe at this point, I could also ask the people on the audience about what they think about ultrasound of the temporal arteries for temporal giant cell arteritis, and how do they use it? Do they use it as a first line screening, or do they use it in lieu of a temporal artery biopsy?
The ESR CRP is high. I've started sending them out for temporal Doppler instead of biopsy.
So let's say if it's negative, do you still go ahead with that TAB?
No, sir.
Or is it you rely on the ultrasound alone?
Yes, sir, because patients are not very happy doing a biopsy.
I see, I see.
I've advised a couple and then they don't come back.
So you find that the biopsy, the ultrasounds, I guess the problem is the way I look at the literature is because ultrasounds are dependent on the person's doing it. So we get variable sort of data. So even in Singapore, I know that the ultrasound data that we get from 2 different institutions seem to be slightly different. So I am still a bit equipoised about the role of ultrasounds. Carmen, what do you think? What do you guys do?
So we can even do a black blood MRI. It doesn't cost more. And if you tell the radiologist, they look for it.
Black blood MRI, huh?
Yes, sir. And it doesn't cost extra. So
that's something we need to explore with our radiologists. What do the guys do in Hong Kong? Carmen?
Oh, previously we used to do a lot of temporal artery biopsies, but now, well, not a lot. I mean, previously, in our very rare cases of suspected GCA, we would do temporal artery biopsy. But nowadays, if the patient is clinically consistent with GCA, we would do temporal artery ultrasound if we can get it, and if it is the temporal artery ultrasound is consistent with GCA would just treat as such and will not do the temporal artery biopsy. I think it's all about the pretest probability. So if the pretest probability is very high, so we clinically suspect it, but the temporal artery ultrasound is negative, we may still proceed to a temporal artery biopsy.
Sure. Our rheumatologists are very keen about doing PET scans. But I'm a little bit hesitant because if you look at the literature carefully, PET scans are very useful for very large vessel vasculitis. So although giant cell arteritis is considered a large vessel vasculitis, I'm just wondering whether it's sensitive enough to pick up craniocervical arthritis. So any of you have experience with PET scans?
Yes, sometimes our rheumatologists would suggest it.
But what's your feel about it?
I think once again, if the patient has symptoms and signs consistent with GCA and the PET CT comes back positive, then we'll just treat as such. I think it will be considered sufficient evidence for diagnosis. However, if it becomes negative, I will still proceed with a temporal artery biopsy if the patient has symptoms and signs.
No, at least recently we had one biopsy proven classic temporal arthritis, and her PET scans done within a short period of the steroids. Of course, steroids will temper the sensitivity of the PET scans, but the PET scan was negative. But I've seen the rheumatologist using PET scan to, like there was another case recently, a patient with classic polymyalgia rheumatica with very high ESR CRP. They did a PET scan, and when the PET scan was normal, they said this can't be GCA. So I'm not so sure whether that is wise, because at least from the case that we had a negative PET scan. So I'll be a bit hesitant about using. So I think what you guys are saying seems very reasonable. If the pretest probability is very high, we would go on and treat anyway. But these tests are useful for patients with equivocal findings, where we are not so sure whether it's GCA. Then there is a adjunctive role for ultrasounds, for PET scans, to relegate the probability, the low to moderate probability of GCA. But those patients with high probability, I think they may not move the paradigm that much. Okay, is there any other comments from anybody else? I hope I have not missed out anybody else. There are some senior people in the audience, so please feel free to comment. And we're very open to criticisms also. Okay, any last comments from Jasmine and Alvin? Yeah, no. Okay, if that's the case, then thank you, Jasmine and Alvin. And we'll hand the podium over to our guest today. So we are privileged to have Dr. Verna's team from Coimbatore, Aravind, presenting some of two of our cases. So Dr. Verna, please take over.
So good evening, everyone, and thank you, Umapathi sir, for giving us the opportunity to present. So the first case, our resident, Dr. Manisha, will be presenting.
Good
afternoon, everyone. Dr. Manisha, I'll be presenting a case which I saw in the OPD during my neuro-ophthalmology posting, which I've titled as Papilledema led as the first clue, an unusual diagnostic journey. My patient was a 39-year-old female, came with complaints of headache, vomiting, and tinnitus. And she was symptomatic on and off since 2 years. And she also gave one episode of seizure around 13 years ago, which was not adequately investigated. She had no other significant history. There was no focal neurological deficits also. On clinical examination, anterior segment was was completely within normal limits. There was no RAPD. And on fundus examination, can anyone tell me what we are seeing in this fundus photo?
Alvin, I think, okay, maybe we'll ask Alvin to point to our trainees here.
Maybe get Kai. Oh,
Dr. Kai.
okay.
Yes. So, lady presenting with what's your studying? Headache, vomiting, and then has got this disc appearance.
Yeah. So of note on this fundus photo, I noted that bilaterally the disc appears to be swollen. Otherwise, I do not note the presence of any peripapillary hemorrhages. There's no Penton's line. Yeah. These margins appears to be quite blur, but the vessel is not too obscurated. Yeah.
Thank you so much, sir. Okay, so that's very correctly put. The fundus photo shows bilateral disc edema, which was consistent with recent grade 3 papilledema. You can also notice that the discs are both slightly pale. Then we went on and did an HFA, which showed.
Okay, Dr. Kai.
Bilateral.
Dr. Kai, welcome.
Yeah. Okay, so these are the Humphrey visual field 10-2 of both eyes. It appears that there's a quite constricted visual field. Yeah, bilaterally.
So consistent, right?
Yeah.
So, Dr. Manisha, can I ask Dr. Kai about what he's going to do for this patient?
Yes, sir, definitely.
Yeah. Dr. Kai, what are you going to do?
I would like to, ocularly, I would like to further check, send for optical coherence tomography of the retinal fiber layer as well as the ganglion cell and inner plexiform layer. I also like to just to check the optical function, checking the RPD, the color vision.
You just mentioned just now.
Oh, okay.
No RPD, vision is full.
Check a contiguous nerve as well. See if there's any involvement of contiguous nerve. Also do a full neurological examination to see if there's any long tract sign or cerebellar sign.
But what are you specifically worried about?
Whether there's any like cavernous sinus thrombosis.
What do you think?
Patient with bilateral disc swelling.
Bilateral disc swelling, vomiting, headache. Do you think there's time for OCT?
No. So I should
May not be safe.
neuroimaging.
Yeah. So first examine the patient for evidence of raised intracranial pressure, right?
Yeah.
So then you break down the constituents of the head. There's neurons, there's CSF, there's blood vessel. Okay, so you think about all those, and Monro-Cayley principle is that if one volume increases, volume of one of these things increases, the blood pressure. If you go systematically, what are the pathologies of the neuron, pathologies of the CSF, pathologies of the meninges, okay, because the constituent, and then the pathologies of the blood, then you will be very comprehensive.
Yeah.
Okay, so give us some example of pathologies of the neurons.
Neurons.
It could be encephalitis.
Yeah.
What about tumors of the neurons, primary and secondary tumors?
Meningioma.
Good, meningioma.
Yeah.
Don't worry. Yeah, it's a learning process.
Yeah.
So meningiomas and things like that, right?
Yeah.
Or neuromas, neuronal tumors like gliomas and things like that, right? Yes. So then after that, you have infections in the neurons, right? Whether it's encephalitis, neuron itself, encephalitis or brain abscess.
Okay.
Okay, these are all life-threatening conditions.
Yeah.
Then you come to the meninges. The meninges can be swollen and inflamed because of various forms of meningitis, bacterial, viral, tuberculous, cryptococcal, all the various forms of. Then you come to CSF. The CSF can be either excessive or blocked. Right? Yeah. So it can be hydrocephalus or CSF increase as in communicating hydrocephalus. Okay. Then blood vessels. Anything in the blood vessels that cause papilledema and vomiting
like ruptured aneurysm.
Ruptured aneurysms like subarachnoid hemorrhage and things like that. But more importantly, in a female who comes to you with headache for a while, maybe 1 or 2 days, which venous?
Which venous?
Which compartment gets blocked off? Not the arterial compartment, but the venous. So that's known as cerebrovenous thrombosis, right? Yeah. So essentially, if you go break up the thing into a systematic checklist, then you're more likely to. I don't think did I miss out anything? I think we've covered most of it. Then, of course, one more thing. Under arteries, you must remember that the pressures of the arteries may have been very high, and therefore the brain may swell. So, press and hypertensive emergencies. So, in eclampsia, for example, or patients with very severe hypertension, when it's very severe hypertension and involving swelling of the posterior part of the brain, we use the word PRES, press. Yeah. So that's another, but again, it comes under blood vessels. Okay. So that's another medical emergency, right? Now, so in idiopathic intracranial hypertension only comes in when you've ruled out all these possibilities, right? So it's not something we'll consider at all. So as an ophthalmologist, you will send this patient to the emergency department for more further management, right? Good. Dr. Manisha, do you agree? Did I miss out anything?
Yes, so thank you so much for the beautiful classification of the differential diagnosis. We had kept all these in mind, and then we sent the patient for the neurologist evaluation, and they had advised an MRI brain, and the MRI brain showed non-specific bilateral hyperintensities, and also she was advised to undergo an MR venography, which showed bilateral transverse sigmoid sinus stenosis, which was again suggestive of idiopathic intracranial hypertension. And then again, a CT brain was taken. And this is an axial section of CT brain showing symmetrical bilateral basal ganglia calcification. So following this, when the patient, the patient was also sent for a metabolic evaluation, which showed the following findings. There was hypocalcemia, hyperphosphatemia, and low levels of parathormone. Levels of vitamin D, albumin, liver and renal function tests were normal, and the neck USG also showed normal findings. These findings were consistent with primary hypoparathyroidism. And when the patient came back, we elicited this particular sign. But anyone tell me what we are eliciting here?
It is specifically the hyper. It's for the hyperparathyroidism, right?
Yeah.
Okay.
Dr. Kai, you want to tell? Oh, do you remember? Anybody out there? Medical students in the audience? Medical students?
Can be the other version, right?
Shovstack sign.
Shovstack sign, yes.
Okay, medical students need the answer. Shovstack sign.
Yes, that's correctly said. It's chopstick sign. So what we have done here is that we have tapped over the facial nerve just anterior to the ear, which caused twitching of facial muscles, which indicates neuromuscular excitability. And what would this indicate? If chopstick sign is positive, sir, what are we suspecting here? Can you let me know?
Hypercalcemia.
Hypocalcemia.
Yeah, correct. So we this raises a suspicion of hypocalcemia. Then keeping in mind all the findings that we have got till now, we came to the final diagnosis of chronic papilledema secondary to hypoparathyroidism associated FAR syndrome. And the patient was managed.
Maybe I'll just explain a little bit here. So I think, so just now, we had a very interesting checklist, right? But in the checklist, we didn't have hypocalcemia as a cause of papilledema, because actually, before you showed this case, I didn't think of that as a possible cause also. So you're going to tell us why we have to think about hypocalcemia as an unusual cause of papilledema. Important because all of us work in tertiary centers, and it's likely that we may see one of these patients one of these days. So it's important to understand how systemic disorders like hypocalcemia can do that, because I don't think it's part of our workup to do calciums, right? Yeah. So that's one. And secondly, of course, we have to remember that this patient did have some symptoms of hypocalcemia, right? She's known to have seizures and some systemic features. Okay, maybe I'll just also explain this term FAR syndrome, because sometimes there's some confusion. So it's just an eponymous term to refer to bilateral basal ganglia and diffuse calcification in the brain. That's just noted on the scans, right? So then after that, you have to start thinking, what is the cause of this syndrome? So it could be many things, right? And one of them is hypocalcemia from hypoparathyroidism. So the name FAR syndrome just refers to bilateral diffuse calcification of the brain. Now, if there's no cause found and the patient just has bilateral calcification of the brain, then the patient, then we use the term FAR's disease, which is just an idiopathic condition, right? So fast
Yes.
syndrome is just a description. So in this case, what is critical is that the patient's pathophysiology is related to hypocalcemia. So hypocalcemia causing raised intracranial pressure and papilledema. So now you're going to teach us why hypocalcemia can do this. Please go ahead, Dr. Manisha.
Yes, sir. Yes, I'm coming to that, the mechanisms of how this could have possibly led to a raised intracranial pressure. So this patient was first of all managed by the endocrinologist with oral supplementation of calcitriol and calcium. So calcitriol is like the active component of vitamin D, and these two together will supplement the loss of the hypocalcemia levels that we have in our body is mainly because of low parathormone level in this condition. So this active form of vitamin D along with calcium is the combination that is needed to treat when the patient is symptomatic. And she was also advised endocrinology follow-up. And we also advised her to come back for serial ophthalmic monitoring, but unfortunately, she failed to follow up with us. So here's a brief background as to
do we know that her papilledema resolved with treatment of hypocalcemia?
No, sir, because she came only for the first visit, which was 2 weeks after our initial diagnosis. So then after that, we couldn't follow her up because she didn't come back to us.
Yeah. So I think this is a problem in the Global South. I notice we often don't have the privilege of seeing the patients again. We often lose them for various reasons. Sometimes they can't afford to come back, or sometimes they are too far away. So, but maybe you could also tell us from your literature review whether treatment of hypocalcemia will reverse the papilledema. Perhaps you will come to that. So maybe.
Yes, sir.
Yeah. Thank you.
Yes, sir. As we all know, papilledema is the bilateral optic disc edema secondary to raised intracranial pressure. And chronic papilledema may lead to irreversible optic nerve damage and visual field loss. And persistent cases warrant evaluation beyond common etiologies. And coming to FAR syndrome. FAR syndrome is a rare disorder with less than one symptomatic case per million population, typically presenting in the 3rd to 5th decades. And it's basically, as sir told, it's bilateral basal ganglia calcifications, secondary to abnormal calcium phosphate metabolism. Because here it's FAST syndrome, whereas in FAST disease, it is idiopathic, where the metabolic profile would be completely normal. And the patient, even in the literature workup that we did, the patients classically present with movement extrapyramidal symptoms like movement disorders, seizures, and neuropsychiatric symptoms. Papilledema as an initial presentation is extremely rare, which makes our case special because in case of FAR syndrome, patient has first come to the neuro-ophthalmology OPD from where the workup has started, and we have diagnosed this metabolic disease, and which led to the early metabolic correction and further neurological progression could be prevented. So these are the proposed mechanisms of papilledema which may occur in FAR syndrome. One possibility is that if the hypocalcemia is so bad that the patient has recurrent seizures, that can lead to transient cerebral edema and raised intracranial pressure. But that is not a possible mechanism here because the patient had just one episode of seizure, that was 13 years ago. So the next possibility is that there can be, because of this extensive perivascular calcification, there can be impaired venous drainage, which can also lead to raised intracranial pressure. And another possibility is that hypoparathyroidism as such can lead to an idiopathic intracranial hypertension-like state, causing a raised intracranial pressure, which we think is the possible mechanism here. Sir, any input on this?
So in your literature review, these patients who are treated for hypocalcemia, does the pressures normalize?
Yes, sir. I've seen a few cases, and the largest case series that I saw was from a clinical setting in Morocco, where there was a group of 5 patients with FAR syndrome. And again, that was also FAR syndrome because there was primary hypoparathyroidism as an underlying cause. And their presentation was also heterogeneous, as you've seen, mostly extrapyramidal and with history of seizures. All the patients have improved with calcium and calcitriol therapy, which emphasized the reversibility with early treatment. And so yet another case that I came across was from the World Journal of Clinical Cases, which again showed that this was just a single case report where the patient had presented with Parkinsonism-like symptoms, where there was slow response, speech difficulty. Again, Chopstick sign was positive. And the metabolic profile was also in the same way that we have seen here. Again, in this case also, there was an improvement after receiving intravenous calcium gluconate. Another case report is from India. This case I've specifically chosen because this was one of the very rare scenarios where the patient came with some visual symptom. There was a progressive visual impairment, but this was only a functional complaint, and there was nothing structural to in this case as well. So, which again makes our case very rare on this front.
Actually, I just wonder, based on this, how many times we see patients with hypocalcemia in the internal medicine wards, but maybe we didn't look in the fundus hard enough, because maybe papilledema is not an unusual manifestation of hypocalcemia, because everyone is treating the hypocalcemia and all the systemic manifestations, right? So
yes, sir.
Maybe the fundus is not really carefully looked at, especially these days where routine fundoscopy is becoming less and less routine, right? So
Yes.
which is not a good thing, of course, but so again, another my pitch to the physicians to make a fundoscopy part of a routine exam, so that we can pick up these things. There's some questions in the chat about the possibility of there being drusen also. So as a neurologist, I shouldn't comment about drusen. So we'll ask Alvin, what do you think? Is there some drusen there?
I mean, there wasn't any.
Can you show us the picture again?
Yes.
Yeah. And
there was some small bit.
I think Samir in there. Let's look at the picture number 4. Yeah. He mentioned it looks a bit bulky.
Right.
Yeah.
Maybe the left nerve looks a bit bulky. But I mean, in both cases, the margins are quite blurred. Anyway. And we probably need to do some more imaging to rule out any potential topic this juice.
Did you guys there was any when you were seeing these patients, did you think there was drusen also? Sorry. The doctor's name is Dr. Man.
Sir, we didn't do this. We didn't do it.
Dr. Verna, we can't hear you. We can't.
Yes, sir.
B scan was done. There was no drusen picked up on the B scan.
Great. Okay. So that's good enough.
Yes. Yes, sir.
Good. Okay. So I guess, okay, thanks, Dr. Shamir, for the question. So I think any other questions from our other experts? So we should add this to our workup for this swelling. Besides anemia also, right? Because in the global south, we also see patients. I think Verna showed me a few patients when I was there, anemic patients presenting with IIH-like picture. Not obese.
Yes, sir. We have a case series of that, sir. Now.
So they are not obese, but they are very anemic, and anemia is another factor.
Dr. Kalpana here.
Yes, Dr. Kamana.
Yeah, just this, what about this transverse sinus stenosis, which was noted on the MRI?
Yeah, good point. Thanks for reminding us. What do you all think, Dr. Verna, about the transverse sinus? Is it significant?
Sir, that gave us the clue of, again, idiopathic intracranial hypertension. So that is why we came to the hypothesis that it is a case of hypoparathyroidism, which created an IIH-like state, which led to the raised intracranial pressure and hence the papilledema.
Okay. So they were quite sure that it's stenosis, is it?
Sorry, sir?
Quite sure.
Yes, sir. Yes.
Because, again, just like what we said about ultrasounds of the temporal arteries, so stenosis is something that there's a lot of arguments on whether it is chicken or the egg, whether it is really the cause of IIH or is it, we shouldn't use the word IIH here, whether it's a cause of raised intracranial pressure or is it an effect of it. So, but unfortunately, we don't have any follow-up on this patient, right?
Yes, sir. We don't have any follow-up on this patient.
Was there any other case in the literature about hypocalcemic patients also having narrowed cerebral veins?
No, so I could just pick up just one patient who presented with a visual symptom. There were no visual signs or no other investigations on that front.
So I think a lot of these cases, because we do work up all our patients with this swelling with at least a CT scan, right? So the CT scan will pick up the
Yes.
calcifications, and the calcification workup will involve calcium. So we will pick up the hypocalcemia. And then we will also
Yes.
be looking at the cerebral veins. So we will pick up if there was any stenosis or cerebral venous thrombosis. So in that sense, I think, like you said, it is probably an uncommon cause, but nevertheless, a very important reminder for us to remember our general medicine when we see patients in the eye ward. Okay, any other
Yes,
comments from anybody else? If not, we'll move to the next case.
Thank you so much, sir.
Thank you.
So our next case is presented by Dr. Krupin, and we have Dr. Sarvanan here, who's the head of the retina department.
Thank you. Thank you, sir. Welcome.
Good afternoon to one and all. So my topic for today is when an enlarged blind spot tells you a story. So a 30-year-old female came with a complaint of defective vision in the right eye since 5 days.
I think
So she gave a
the slides are not changed yet. We still see the previous slides, Dr. Manisha's slides.
Now, sir, is the slides visible, sir? Are the slides visible?
But it's not on. It's not on projector.
Yes, sir.
Okay.
So now,
Perfect.
okay, thanks. So a 30-year-old female came with a complaint of defective vision in the right eye since 5 days. So she gave a characteristic complaint of seeing of a small non-seeing area to the temporal side of the right eye. There were no history of associated floaters or flashes. There was no history of ocular pain, no history of head injury, headache, nausea, vomiting, giddiness, or any weakness of the limb. No history of fever, no history of recent vaccination. So on examination, vision was 6 in both the eyes. Anterior segment was normal. No RAPD in both the eyes. Color vision was normal. This is the fundus examination of both the eyes, which looks normal. So then we proceed with the fields. So could anyone explain me the field over here? There's a right eye and the left eye.
Okay, wait. Dr. Alvin will appoint somebody.
Yes, Josh, please.
Josh, is it?
Yeah.
Josh. Okay, Josh, you want to come forward?
Okay, sure. So basically, the patient comes in with some visual field defect.
Yeah.
Fundus photos appear normal, and this is like a large blind spot. Okay. Is there any other things you consider?
Just comment on the visual fields for us.
I mean, the left eye visual field is not the most reliable. It's high fixation losses, and no specific pattern of defect.
The left eye.
Yeah, and the left eye.
Complaints are right
eye. The right eye itself. I mean, it's just some. I mean, it's fairly reliable, other than the nasal defect.
There's a defect in the nasal.
Yeah, the nasal aspect, but I don't think really follows any pattern. I mean, other than that, and plus for a blind spot enlargement, yeah, suggesting. Yeah.
So you're right. So the right eye showed a blind spot enlargement, whereas the left eye was normal.
Okay.
So in this, so after that, we tried to do an OCT. The OCT of the left eye on the disc was normal, whereas in the right eye, could anybody tell what, especially in the parapapillary area, could anyone find anything, any abnormality?
Okay, Josh will teach it. Yeah. What do you see?
I mean, at the retinal fiber layer, there's like hyporeflective lesion. Is that supposed to be like a?
Just try your best because we have a retinal expert there
Yeah.
to help you. Just try your best.
I mean, honestly, I'm not too sure. Is this supposed to like represent a drusen or something? I'm really not too sure.
I'm
Yeah.
not sure. Huh?
Yeah.
Anybody knows? Again, I don't.
So over here, as you can see, there's this line which shows the photoreceptor layer loss. So here there's this characteristic photoreceptor layer loss disruption over here. As you can see, this is the line which is the continuous line. But over here, there's this layer of disruption. So we see a right eye layer disruption, which is confirmed over here. Fundus autofluorescence was done, which was again normal. We did the fundus fluorescing angiography. The left eye was normal, whereas the right eye showed disc leak with the late staining with the disc leak was seen in the right eye. A multifocal ERG was done. ERG in the right eye showed a depression of a parafoveal amplitude over here, whereas the left eye was normal. So now we have a patient with blind spot enlargement in the right eye with a peripapillary PR layer disruption and mild leakage in the FFA. So we did the routine blood investigations, which was all normal. A MAN2 test was done to rule out a TB-related inflammatory pathology, and an MRI brain was done to rule out any optic neuritis or any other neurological complaint. So after this, differential diagnosis of enlarged blind spot would be an optic disc drusen, which a fundus fluorescence and B scan would have picked up. Acute zonal occult outer retinopathy, again an autofluorescence would have picked that up. Optic neuritis, MRI would have picked that up. A tilted disc, we would see a fundus on the fundus photo. We would see the tilted disc, and again the MRI or the B scan would pick up papilledema or if there's IIH. So after ruling out all these causes, we came to a diagnosis of exclusion, which is acute idiopathic blind spot enlargement syndrome. So do you have any other possibilities or any thoughts or any other differential which you could have thought of?
Mostly neuropophthalmologists in the audience. Huh? So we have teachers about this. There are general ophthalmologists here. Are there? Aravind, can you identify general ophthalmologists who can talk about this? Oh, we have somebody. But it's okay, you're more general than us.
Do you know any other causes of blind spot enlargement?
Optic neuropathy. Other form of optic neuropathy like inflammatory or uveitic related causes like white dot syndrome or macular causes, which the optical coherence tomography of the macula should pick up, but there wasn't any. And how do we, maybe I have a question for the team, how do we relate the outer receptor loss?
Come forward and ask. Yeah.
Is there a
Receptor loss.
Yeah, so there's a question from one of our residents.
Yeah, well, I'm just wondering why is there outer photoreceptor loss at the peripapillary area? If we think it's acute idiopathic blind spot enlargement.
We couldn't get the question. Photoreceptor loss, pardon me? Huh?
Why was there
why is there loss, right?
Yeah, why is there outer receptor?
Why is there loss? So I'm coming to the pathophysiology. So basically, there was a photoreceptor loss and an enlarged blind spot. So what we thought is we wanted to rule out all the causes which would lead to an enlarged blind spot on HFA. So these were the investigations which were done to rule out the causes of an enlarged blind spot. And we came to a diagnosis of acute idiopathic blind spot enlargement syndrome. Why the PR layer loss? I'll just come to that. This belongs to a spectrum of primary inflammatory choriocapillaropathy. So basically, there's a choriocapillary inflammation over here leading to the PR layer loss. So in this spectrum, there is acute zonular occult outer retinopathy, multiple evanescent white dot syndromes, multifocal choroiditis, and acute idiopathic blind spot enlargement syndrome. So this is the entire spectrum is where this disease is a part of. So it is commonly found in young to middle-aged females. Symptoms would present as an acute monoocular photopsia, visual loss in the blind spot area, and usually it's not associated with pain. So etiology could be idiopathic, it could be post a viral infection, post vaccination, and due to an autoimmune reaction. So pathogenesis is it's a primary choriocapillaropathy. There is chronic inflammation of the choriocapillaries, choriocapillary non-perfusion, which leads to a choriocapillary non-perfusion, secondary ischemia, which again leads to an outer retinal dysfunction. This explains your photoreceptor layer loss. So a clinical staging which was given by Liu et al., in which there's an acute phase which has mild inflammation with mild fundus changes. Then there's an involution phase in which the inflammation slowly reduces. The chronic phase where the lesion can grow, and recovery phase where the OCD changes resolves. So probably our case was in the involution phase. So symptoms, again, as we discussed, was acute monocular photopsia with enlargement of blind spot. Visual acuity is usually unaffected. Fundus examination is usually normal, but there might be faint blurring of the optic disc margin. So as you can see over here, characteristically, there is a photoreceptor layer loss in the peripapillary region over here, and OCT showing a enlarged blind spot. Again, a multifocal ERG will show depression of parafoveal amplitudes. Further for a diagnosis, and fundus fluorescent angiography will show optic disc leakage with staining. So this is a self-limiting disease. Visual symptoms improve usually by 3 to 4 months, and role of oral steroids is still controversial. So when we come to a differential diagnosis, first would be an optic neuritis. It is usually often misdiagnosed with an optic neuritis. Similarities is both present in a young female gender. It presents with unilateral acute visual symptoms, and it could be, if there's a retrobulbar neuritis or like a picture, there would be very few fundoscopic changes. But again, the differences are many. Optic neuritis would characteristically have an RAPD. It would present as an ocular pain. The visual loss would be significant. Again, central visual field would be, there would be a central scotoma. Color vision would be defective. If there's a disc edema, there would be an increase in RNFL thickness on the OCT. And on an MRI, retrobulbar or intraorbital segment would have been swollen. So this is a case of an optic neuritis showing a disc edema and an inflamed optic nerve. Second diagnosis is an acute zonal outer retinopathy or AZUR. Both presents over here with photopsia. Visual field loss on perimetry without decrease in visual acuity. Again, young females around 30 years, and OCT in both these will show changes in the PR layer or atrophy of the PR layer. Over here, as you can see in the fundus photograph, there's a characteristic demarcation line over here, which shows the difference between the normal retina and the abnormal retina. Over here, the PR layer is there's significant disruption, and the symptoms are usually much more in an AZUR as compared to a blind spot enlargement syndrome. So over here, you can see the fundus autofluorescence is showing speckled hyperautofluorescence, indicating the activity due to the disease. And OCT, if you see, there's a characteristic disruption of photoreceptor layer, which is much bigger than what we see in our case. Fields will again show a blind spot enlargement in both the eyes. But the difference, again, as you can see, AZUR is a bilateral condition. So ERG changes will be bilateral. Exclusive enlargement of the blind spot is rare. You will mostly see a multifocal field defect. AZUR, there's a lot of recurrence, and there's a very poor recovery of photopsia and the visual field. So this is a case series by Zimmerman et al., in which 3 patients aged between 25 to 27 years presented to the neuro department with a unilateral acute onset photopsia with blind spot enlargement on the temporal field without actually any visual acuity reduction. In all the patients, fundus examination showed no to mild blurring of disc margins. Perimetry shows auto blind spot enlargement. So you can see over here, the photographs of the optic disc of the affected eye shows a mild blurring of disc margins with mild peripapillary color changes. Again, in the fundus autofluorescence, it discloses circular irregular hyperautofluorescence of the peripapillary retina. Again, the OCT for these cases, there's a peripapillary irregularity, as you can see here, and hyporeflectivity of the retinal pigment epithelium Brooks complex. All these cases over here, you can see. The interdigitism zone and the outer segments of the photoreceptor layer. Whereas the unaffected eyes, as you can see over here, were all normal. Intravenous fundus angiography depicts mild hyperfluorescence and staining of the optic nerve head edges without significant leakage, as you can see over here. So both the 2 cases were started on treatment with tablet methylprednisolone weekly on tapering doses, and you can see on follow-up the blind spot enlargement has significantly reduced. So you can see over here, there is a restoration of the outer retinal layer. Image C shows a partial restoration of autofluorescence, and image D shows a reduction of size of atrophy of the outer retinal layer. So it could be accurately diagnosed with a peripapillary OCT, perimetry, and a lack of distinct RAPD. Early treatment with corticosteroids may support outer retinal reorganization, restoration of the visual field. This is another case report by Hema et al., in which a 31-year-old female complained of blurring vision in the left eye. Visual acuity was normal, color vision was normal, anterior segment examination was normal. Autofluorescence over here, we can see peripapillary and temporal fovea hyperautofluorescence. OCT over here, as you can see in the left eye, there is a PR layer disruption at the peripapillary area and temporal to the macula, corresponding to the hyperautofluorescence layer on the autofluorescence. Left eye showed a blind spot enlargement. Over here, the OCT angio was done. As you can see, the right eye, this was at the choriocapillary section. The right eye, the choriocapillaries was normal, but if you see the left eye, there's significant coarsening of the choriocapillaries, hence proving that this is an inflammatory choriocapillaritis. So OCT is a neurodiagnostic tool, OCT angio is a neurodiagnostic tool which helps in the diagnosis of this condition. Xavier et al. Again published a case of a 57-year-old female which complained of a disturbance in the right eye 11 days following an administration of influenza vaccine. Vision was 6/6, color vision was normal, anterior segment was normal. You can see over here, right eye shows a mild venular dilatation at the edge of the optic disc, whereas left eye was normal. A multifocal ERG, right eye showed a decreased wavelet amplitude in the macular region. So, my take-home message would be blind spot enlargement syndrome is not a disease of the optic nerve. It is a disease of the outer retinal layer. It is commonly misdiagnosed as optic neuritis, and a multimodal imaging plays a key role in diagnosis. It is a self-limiting disease, and role of steroids are still controversial. I would like to call on Dr. Saravanan sir for further discussion.
Already pointed out, there's a more of exclusion diagnosis. So in our case, the photopsia was not there, probably because the area of involvement is very, very small. And that also made it a little bit difficult for us to come to a diagnosis also. We had to go through the OCT scans to really look at the subtle findings. When he showed the other cases, you can see the gross changes, which are much more obvious. In our case, you can see the, next. Yeah, you can just see here, this is the integrity line, photoreceptor integrity line, that white line which comes and starts getting granular and disappears towards the optic disc. It's more seen here, and so you can see this is the PR layer, integrity layer, and it stops here, and this area is lost. So this is the area which is involved, and if it's much more profound and easily diagnosable in most of the cases, which is already some of the publication which Dr. Krutin showed. Our case was very subtle, so that's why her, even though symptoms were there, the photopsia symptom, which is much more characteristic, was absent in our particular case. And we did the multiple OCT scans. This was the area where the PR layer was lost. And this was the area which was sort of correspond to the HFH, where the enlargement of blind spot was noted. So mainly we have to do multiple OCT scans, either radial or raster lines, with the disc at the center to identify this particular pathology, especially if it is very subtle and the area of involvement is very small.
Then can I ask, then would you do like syphilis and TB check in this kind of cases?
TB was ruled out by the MAN2, and the syphilis was again the FTF antibodies all were done, which were all negative.
Oh, okay, thank you.
So the workup will include things like post-infectious, post-vaccination, TB, syphilis, that kind of workup, is it? Okay.
Yes.
Thank you.
Wow, very nice. I think many of us may have treated this as optic neuritis. So I think I've got a feeling I must have missed a few of them because unless we look at the HVF very, very carefully, right? So thanks so much for bringing this up. Any comments from anybody else? We are just past 6:30 Singapore time. Carmen, do you have any from your side?
No, I think
good evening, Prof. This is Dr. Sunday Commando Maji from Nigeria. I learned a lot in the whole of the presentations. I'm grateful for the invite. I look forward to joining you.
Potential fellow.
Future ones. Thank you very much. Yeah.
Yes. Welcome, Sandy. So, Carmen, do you have any comments?
Oh, I was just, well, very nice case. I was just thinking that because AIBSE and AZOR are a continuum, sometimes a full field ERG would help to differentiate between them because AZOR would be expected to have a more widespread retinal dysfunction, whereas
Exactly.
yeah. So, but in which case, I think sometimes, the role of steroid, as you say, is controversial. So, and sometimes in these cases, whether AZOR or AIBSE, the characteristic is that there's at least partial recovery of the outer retinal structure as we follow them in due course. Yeah.
So especially the involvement is not very severe. Most of the times you can see that the follow-up OCTs after 4 or 5 months will look normal.
Yeah. Thank you. Interesting case.
Thank you. Thank you very much. So I think I must really thank Dr. Verna's team, Dr. Sarvana and Dr. Verna's team for this excellent teaching session. We learned a lot from your cases. Hope we also contributed with our diagnostic problem. I would also like to thank Ms. Megan, who superbly arranged all the audiovisual stuff so that we all can see and hear each other very well. And maybe I can ask her to put the advertisement for next Tuesday's session, where we're going to have a special session again for our global health program. So I hope to invite all of you guys to join again next week around about the same time, where we will have 3 experts talking about their work in remote parts of various parts of the world, and to teach us about how we can provide standard care in under-resourced parts of the world. So with that, thank you and see you next week.
Thank you. Bye-bye.
Thank you, sir.
Thank you. Bye-bye.
Thank you, sir. Thank you so much, sir.
Okay. For this, please enjoy the pizza. Is there still any pizza left? No, pizza's on top. No, still there. Okay. Thanks very much. Thanks. I'll send you pictures of it.